30 years. You think it's 30? Oh, you have one? And it was not an emergency?
Yeah, it was.
Oh, but see, we're still doing it, even last week for emergencies.
Well, but it wasn't an emergency like.
Not life-saving, so urgent,
It was urgent, yeah.
not emergent.
Yeah.
Okay.
And I had a VBAC after that.
Oh, wow, with a classical uterine incision. Not just a classical skin, because you can have a classical uterus and a different kind of incision in your uterus. Wow, that was a brave healthcare team there. Any questions about cervical dilatation and effacement? What it means, how do we measure it? Okay. All right, so changes in the other systems. Changes during the contractions of the cardiovascular system. What happens during a contraction related to the cardiovascular system? I mentioned it last week, but what happens is 300 to 500 milliliters of fluid is pushed from the uterus into the vascular compartment of the mother. That's a lot, right? And that happens with every single contraction. So you can imagine that's going to be a strain on the heart, right? Okay, so that's important. And we'll talk about that with Pitocin, and it's even more important. Positioning is really important during labor. Number one, change the position of the patient. Number two, avoid what position? Supine, flat on the back. Did anybody see laboring patients flat on their back last week?
No.
I did. Not last week, but 4 weeks ago, I think. So it's not, I mean, on the left, on the right, and again, it doesn't have to be propped up on their side, but at least something under their hip to tip them up a little bit. Not supine, okay? That's not supine. Supine means you're flat on your back, right? Okay. Hyperventilation is not uncommon during labor, especially as we proceed and get into the transitional phase. Because here's what happens, they start with their breathing, and now we don't do any fancy hoo-haws, hee-haws, ho-hos, all that kind of stuff, which you might have done 30 years ago, funny breathing, but now really we just use slow-paced breathing, slow, deep breathing, so, you know, contractions always begin with a cleansing breath, and that just means, kind of gets the woman ready, tells the partner, I don't have to say I'm having a contraction. Patient just does a cleansing breath, they know when's coming, now the partner knows what they're supposed to do, hopefully. Then slow, deep breathing. So as it's going up, it's like, as the contraction's moving, it's like, get that? When they hyperventilate, it's usually when they get to the peak and they're going, but I'm not going, but you know, this is about to make me dizzy now. But you're breathing very shallowly across that top of the peak. I used to say to women in way back in childbirth teaching days, just let the air hit the back of your throat and put it back out. So you're not going, you're just going. See how that's different? You're not usually going to get hyperventilating with that. Now, what kind of symptoms does your patient have if they're hyperventilating?
Dizzy, lightheaded.
Dizzy, lightheaded. Anything else? What about their extremities, especially their finger?
Tingling.
Tingling, yeah, tingling fingers, dizziness. And what's the treatment?
Oh, blowing up a
A paper bag.
Are you sure it's paper, not plastic?
Yes.
Now, we're in a hospital, though. Is there nothing more technologically advanced than a paper bag? No, there's really not. That's your question. No, blow on a paper bag.
I bet you just tell them to put their arm from.
You can do that until you get a paper bag, but a paper bag is more efficient, because what makes them dizzy? What have they done when they hyperventilate?
Blowing off the CO2.
They blew off too much CO2, so we need to get more CO2, and that's in the bag. Yeah, you can catch some in your hands, but that's also a little suffocating, so a bag works better if you have it. Okay, GI is decreased motility during the process of labor and birthing. The important part of that is, if they've eaten recently, it's not moving, so wherever it is, it may stay. So if you say transition time from mouth to stooling is, 6 to 8 hours, theirs might be 12 to 14 hours or something. And if it stays and their labor progresses and it's still in their stomach, then they're likely to throw up on you during the process of transition. the third phase of the first stage, or if they have to go for an emergency cesarean and need to be intubated. Not everybody, and in fact, very few women will be intubated, paralyzed, tube down their throat, and connected to a ventilator during the process of C-section, because that is very dangerous for the fetus. It takes only about 2 minutes for that medicine that they give the mom to get to the fetus. So they've got to go fast, 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 okay? So you'll see them, they're all ready to go. They've got scalpel in hand. As soon as anesthesia gives the word, they go. But most women, 80% of them, usually already have an epidural in place, so they'll just top them off, give them some additional medicine, and numb them up for the cesarean. If it's a planned cesarean, what anesthesia do they usually use? You know? It's still regional, but it's a spinal. Because the effect of the spinal is immediate. And that's important for who? The surgeon. Because they don't want to wait 30 to 45 minutes while we see if the epidural is going to be fully in place and working. They want to do it right away. The other thing is, there's a rule in surgery, and I don't know if you know the rule, but no anesthesia of any kind can be administered until we see the eyeballs of the surgeon. They can't say, I'm in the parking lot, I'm in the elevator, I'm in my office, I'm dashing across the bridge now. You got to lay your eyes on them, because anything can happen in between that time. You can't anesthetize the patient until the surgeon's there. Okay? So once the surgeon's there, I assure you, they really don't want to wait 30 minutes or 45 minutes. They want to, like, while you're scrubbing, they want you to be getting everything ready. Time is of the essence. Urinary system, decreased sensation. So evaluating for our patients' bladder filling is our job. It is the nurse's job. And it can completely stop labor. If the bladder gets full, it can completely stop labor. So now you're going, la-di-da, everybody's happy, and then it slows down, slows down, slows down. Might be a good idea to evaluate the INO, because if she's anesthetized, she may not feel her bladder filling. And also, if even if she's not anesthetized, you have some decreased sensation of that. I mean, there's a lot of stuff going on down there, so usually filling of the bladder is not, on the forefront of their mind. So sometimes in labor and birthing, once a patient has to be catheterized, the order will read, and they're all different, but the order might read, in sort of Foley. You don't get 2, 3 shots, you're out. You get a Foley right from the get-go. Others will say straight cath times 2 or 3, and then put a Foley in if they need it after that. But probably the prudent thing to do is just put in a Foley, because we know every time you put a catheter in and out, even if you use good technique, sterile technique, there's still a risk of UTI. And we know now that hospital-acquired UTIs are not covered by insurance. They will not pay. What will they not pay? They will not pay for the UA, they will not pay for the UA culture and sensitivity, they will not pay for the medications, they will not pay for any extended stay that's necessary because they acquired that UTI when they came to you.
Now, does the hospital pick up that?
Oh, yes, they do, and that's why now techs in most hospitals, I don't know about all, but don't do Foleys anymore. Not because they weren't good at the skill, but they didn't have the scientific backing and rationale to know why doing it correctly was so vitally important. Such as if you stick it in the vagina, which everybody's done if you've been a nurse long enough, you've done it once, but you don't say, dang, I stuck it in the vagina. Let me just put some extra goop on it and stick it back in there. That is not okay. But, everybody keeps track of everything now. So neither is okay using 3 cath kits for every patient you catheterize. There might be an occasional person you need 3 for, because you don't realize how difficult it's going to be, or you need extra help holding the legs, you need help holding the legs, pulling the legs, and holding a flashlight, or whatever. So sometimes it does, but that should be very rare. So, where do you work at? Do techs do Foleys?
Only in rehab.
Okay, only in rehab.
Like you mean to insert the text, insert the Foley?
Only in rehab at her facility. Anybody else? What about Lakeland?
Yeah, the medical assistants we do.
They can.
They can.
And
At the ambulatory clinic we do.
okay, yeah, I don't know about the hospital. Anybody
I don't
know?
know about the hospital.
used to be, I know, I'm pretty sure Florida Hospital doesn't do it anymore, for text, and that's the reason why, infection. And it wasn't just the infection, because probably the infection had already been there. What was the game changer? Okay, what happens in the hematopoietic? Ooh, I love hematopoietic system. What system is that? It's the blood system. Okay, so blood loss. What is normal blood loss? In a vaginal delivery, it's different than in a cesarean birth. Cesarean birth is a surgical procedure, so we expect some. So, Amelia?
500 for the vaginal.
500 for vaginal.
1,000 for C-section.
Right, and those are normals. Anything over 1,000 in a cesarean will be considered a hemorrhage, and anything over 500 in a vaginal birth will be considered a hemorrhage. Who makes that determination of blood loss? The healthcare provider does. They will use information that you, the nurse, give them. They will use information that they see with their eyeballs, okay? But if there's a discrepancy, they are the one that says how much blood loss. I will tell you, it is not an easy thing to determine because there's all kinds of other fluids in there. Amniotic fluids, sometimes urine, sometimes stool. You get a lot of fluids and things going on during the process of labor. So, experience does count for something. White blood cells, what we find during labor and especially immediately postpartum, they will be what? Increased? Slightly elevated. They can be slightly elevated. Now, normally when we see white blood cells that are elevated, what are we thinking is wrong with our patient? So now, if I'm telling you this is normal, how in the world will you know if they have an infection if you can't use that parameter? Exactly. Look for other signs and symptoms. And those signs and symptoms will depend on which system you're looking at. So if I'm looking at an infection of the lungs, what else besides WBCs?
Chest X-ray.
Shortness of breath, what?
Chest X-ray.
Chest x-ray, adventitious sounds, fever, right? What about a urinary tract infection? Fever, dysuria, frequency, right? All those things, okay? So, and a wound infection, right? We're looking for the Rita stuff. So that's what you have to do because the WBCs may not be usable. Now, that being said, if they're over 25,000, everybody is paying attention to that, okay? Up to 20,000 without any other symptoms of infection or signs of infection, probably we'll just note it and move on through our day, okay? But, once you get over 25,000, that's going to be kind of high. Okay, coagulation factors during pregnancy and during birthing remain increased. And so again, that places our patient at increased risk for cardiovascular accidents, which means stroke, heart attack, clots, embolisms. When you hear cardiovascular, that's usually what you're talking about, okay? Now, for the fetus, this is the effect on during birth. They have decreased blood flow during contractions. Make sense? Uterus is contracting, clamping down. Any blood vessel coming in through those muscles is now contracted, smooshed right down. Normal, healthy labor, normal, healthy fetus, everything's fine. Cardiovascular system for the fetus, the fetal heart rate will change. We already know from chapter 15 the heart rate of a fetus changes when they do what? When they move. Exactly, when they move, it elevates, all right? So we may see some changes, but we should see throughout the process of labor and birthing a baseline between what and what for a fetal heart rate? Between 110 to 160. We should see a baseline established, and then for fetal well-being, we'd like to see what? Variability and accelerations. Exactly. Excellent. Do fetuses have fluid in their lungs?
Yes.
Yes, they do. They have maybe up to 100 mLs of fluid in their lungs. And through the process of birthing and being pushed through the canal for birth, most of that will come out, and whatever's left there will be reabsorbed in the lymph system of the lungs, and they'll be all hunky-dory. Sometimes what makes a difference is a fetus who is cesarean delivered and has had no opportunity to be smooshed in the birth canal. So they sometimes have more. Now, you can take this and use this. This is my picture from my head. I have some others. Oh, I didn't even bring it. But in the past, when we had more points available, I asked you guys to make one. You have it on Cornelius's picture here. I think, again, by looking at it, taking a picture, great. But you're going to learn more if you make your own, okay? Because making your own, you learn. But what this demonstrates to me, and you can put it in any other format you wanted, but that we have 4 stages of labor, and then I've divided the first stage into the 3 phases. Note that the cervical dilatation may be different from your book. Go by your book, which I realize is a little confusing, so hopefully no test questions will look like that. And so it tells you what's happening in each stage, such as dilatation, effacement, delivery of the baby in the second stage, delivery of the placenta in the third, the first 4 hours. And then it goes down into nursing interventions. Notice in the first stage we have a fetus. So there are interventions for the mother and the fetus. During the delivery of the baby, or the fetus, now we have fetus and mother still, but look, now once we get in the third stage, we have interventions for the mother, and there are more than these, this is not complete, and the baby, but now we have a baby, not a fetus, okay? So this is not complete, but it's an idea of showing you what you could do, and you do have to read the book and go through the different sections, and set up your diagram first if you do it, and then like fill it in. Okay, here's what I've got to do while they're laboring. I did not, in my mind, I did not separate the interventions for the different phases of the first stage. I put them all in one. But you could do that if you want. But that might be a way where you could get a better, bigger picture. And you don't have to limit yourself to a piece of paper. If you have a whiteboard at home, do it. Do it on a poster board. Anything that you can do to help yourself get a good view of it. Maybe in your study groups, one person does one thing, another, you talk about it, or somebody reads the book, somebody writes it. There are ways that you can use this so that you can all learn together or individually.
Or will you post those pictures on the campus?
People took pictures. I'll just let y'all share it with each other. They took pictures, and Cornelius has a video, I assume, that's running. So the components of the birthing process, we refer to them as the 4 Ps. The first P being the very important one, called powers. Then, and that includes not only the uterine contraction, but the mother pushing at some point. Then we have the passageway, and that's the birth canal. And then we have the passenger, and the passenger is not just an idle passenger passing along. There are things the fetus is doing in order to try to help it, come out the easiest, fastest way. And then the psychological or emotional status of the mother can have an impact on the process of labor. And we call those the 4 Ps. So this is an example of a birth plan. So why a birth plan, and I don't know why I forgot my thing, but I did. Birth plans are forms or answers to questions or instructions from the couple to the nurse, to the healthcare team, the nursing staff and the healthcare providers about how they see their labor going. What do they want? What do they not want? Some will get as specific as saying, I do not want to have any vaginal exams unless my condition changes. So no random vag exams, nothing like on an hourly basis. That tends to cause more of a management of labor, and that doesn't allow the woman to do it on her own. Some will say, I do not want an episiotomy, I do not want this, I want to be able to eat and drink, I do not want meds, I do want meds, whatever they want. I want skin to skin immediately after birth. I don't want anybody in the room that's not medically necessary. I have 10 siblings, and we are very close, and I want them all there. I mean, whatever it is. Now, once they write that, it's a really good idea that they go over it with their healthcare provider before arriving to the hospital, because they may have things in there that are unsafe. Some patients will write, I do not want fetal monitoring. Well, that's fine. as long as your healthcare provider agrees to it, and as long as you don't have any medications at all, or any anesthesia at all, because when you do, when you get monitored, you know, if you don't have any indication. So there needs to be a dialogue between the patient and the healthcare provider, and hopefully that happens. But this is just, these are some things gone wrong. These are perceptions. Again, this is not how we see things, it's how they see them. So my son was born cut straight from my body and immediately placed on my chest. I've never tried so hard. It was perfect. Tears began streaming down my face as I breathed the birth plan I was giving up. Again, I've mentioned this before. It's their plan. It's their little picture of their story in their head. So we have to try to meet that. And when it doesn't, then we need to recognize that we need to help them integrate what really happened. And they'll use their friends and family to do that too. What happened and how it was okay or not. Because maybe they had a poor outcome at some point, and it wasn't okay, and it never will be okay. Take your time and take away the gut-wrenching pain, but it might not ever be okay. Right? Yeah, that's true. Possible. So here is a fetus's head. Those are those suture lines we were talking about. Suture lines are the spaces between the cranial bone, and those are normal, right? When they overlap, what's that called? Molding. And is that a call to the doctor immediately? No, that's normal. That's one of the things that the fetus can do to help make itself smaller to get through the birth canal. Their cranial bones can overlap. When you go to clinical, feel your baby's heads. Try to feel of one that was maybe a scheduled C-section and one that was a laboring mom who delivered vaginally or even labored and then pushed and then had a C-section. You'll feel the molding on the ones who've been in the pelvis and labored, okay? And I'll tell you the easiest way. The ones who you won't feel molding on are the ones who never engaged in the pelvis, like if they had a scheduled C-section, that sort of thing. The easiest way to find fontanelles, anterior and posterior, is to follow the yellow brick road. And when I say that, I mean start at the beginning of the yellow brick road, because you as a newbie, if you just say, oh, I'm going to go find that, you might not. So start here at the beginning of the yellow brick road. When you see that newborn, if you go crossways like this, you'll feel it. You'll either feel the bump from molding or you'll feel the canal from a suture line. So start there. Use 2 fingers if you want. Don't do this because you don't get a good feel. Do this. Rub back and forth. Feel all the way, and then you'll be like, ooh, there's the big fontanelle, the anterior one, which closes when? 12 to 18 months. Stay on the yellow brick road. Do not get off. Keep going back and forth, back and forth, back and forth, wiggle, 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 and eventually you'll get back here and you'll feel the posterior one. Posterior one is teeny, teeny. So if you just go poking around, you probably won't find it. But if you follow the yellow brick road, you probably will. Okay? So the fetus's head does make adjustments by molding to help it get through the pelvis. Now there's a definition, and you really just have to memorize it, called fetal lie. And it doesn't mean truth in lying, but lie. Like, how do they lie? How are they lying? And there are only 2 possibilities. The fetus can be in a transverse lie, or the fetus can be in a longitudinal lie. In a transverse lie, this refers to, when you talk about the lie, what does the fetus's spine look like in relationship to the mother's spine? What is my spine right now? It's longitudinal, right? Place this fetus here. This fetus's spine is horizontal, or they call it transverse. Okay?
Like the transverse colon.
Yes, like the transverse colon, transverse lie. You have to say the whole thing because there's a different position with the fetus's head and the pelvis that's also called transverse. So you have to use the whole word. Okay, so it's transverse lie. Otherwise you'll get, or the whole phrase, you'll get confused. So it's the relationship of the fetus's spine to the mother's spine. So in this case, this is transverse. Now, over here, this is longitudinal. So my spine, the mother's spine is longitudinal. The fetus's spine is longitudinal. Correct? Do we agree? What if we have a breech presentation? Is it still longitudinal?
Yes.
Yes, it is, okay? So longitudinal will either be head down or not, but their spines are going the same direction. This position, fetal lie, transverse lie, is delivered how in 2017? By cesarean birth. Back in the day of Caesar and Julius Caesar and Jesus Christ and Allah and all those big people. How did this happen back then? Since the beginning of reproductive time. So how did they get out then? They didn't have cesarean.
Do they go in and flip it around?
They surely did. Does that sound difficult? Yes. Was it difficult for the fetus? Yes. Did they sometimes die? Yes. And what about the mother? Yes. Infection, hemorrhage, etc. But it's not like they had a choice, okay? If that happens in 2017, somebody's going to be in a bad place besides the mother or the fetus because we have a choice, okay? So transverse lie will always be delivered by cesarean,